Good evening and welcome to iMed Radiology's MRI webinar, MRI for GPs Consideration and Common Cases. So glad you could join us this evening. My name is Ahmed Youssef and I'm part of the iMed Sales and Marketing team. I'd like to begin by acknowledging the traditional owners of the land on which I'm hosting this meeting today, as well as the traditional custodians of the various lands on which you are based today. I would also like to pay my respects to the elders past and present. iMed Radiology Network is one of the largest providers of medical imaging in the world. Across Australia alone, iMed operates over 240 clinics and performs over 6 million patient procedures each year. We have over 350 doctors, 4,000 staff actively sharing clinical knowledge and expertise, all with the same goal, to save lives and reduce uncertainty. We are committed to consistently delivering high quality and expert care in each of our clinics and in every interaction. We are also committed to working with you, our referrers, as partners. Tonight's webinar is a prime example of this commitment. Did you know patients' requests for imaging can be sent from your practice management software directly to us safely and securely? From here, patients in most regions can book their appointment themselves online immediately or for a time and date that suits them. Digital initiatives such as these have streamlined the process from consultation to diagnosis. The patient journey is enhanced and results are back to you as fast as possible, reducing uncertainty. If you would like to know more information on gaining access to electronic referrals, please visit our website, i-med.com.au. Tonight, we are fortunate to have iMed radiologist Dr. Jourena Li discuss the commonly imaged regions of the shoulder, knee and brain and the benefits that MR imaging can provide. This webinar will provide the opportunity to clarify common confusions surrounding MRI and examine the most frequently asked questions. Facilitating for us tonight is Dr. Philip Perlstein, and I would like to thank Dr. Perlstein and Dr. Li for taking the time out of their busy schedules to prepare and present for us. Just some housekeeping items before we get started. All of our educational events are recorded, and this webinar will be added to our suite of recordings available via our website, i-med.com.au. If eligible, you'll be emailed a certificate of attendance and CPD hours will be lodged on your behalf. Finally, I invite you to provide us with feedback by remaining on the line at the conclusion of the webinar. Your feedback allows us to continually improve our education. So without further ado, I would like to formally introduce to you tonight's facilitator, Dr. Philip Perlstein. As a GP, Dr. Perlstein has had a long-standing interest in sports medicine and conditions affecting the MSK system. In 1988, he founded Midtown Medical Clinic in Melbourne, and in 1993, co-founded the Melbourne Sports Medicine Centre. Today, Dr. Perlstein remains active with both his founding practices at Midtown Medical and Melbourne Sports Medicine Centre, primarily in a management and mentoring role. I will now hand over to Dr. Perlstein to introduce our guest speaker, Dr. Jourena Li.
Thanks very much, Ahmed, and good evening, everyone, and welcome to another iMed webinar, this time, as you've been told, focusing on the use of MRI in general practice. We all appreciate the need for choosing the investigation modality that provides us with the best information in a timely and affordable manner to optimise the care of our patients. Increasingly, MRI avoids multiple investigations and may be the investigation of choice. So this topic is very relevant to our day-to-day practice. We're very fortunate to have such a prominent expert as Dr. Jourena Li to guide us through this process. And we ask you to feel free to ask questions during the presentation using the blue hand icon in the top right-hand corner of your screen. At the end of Jourena's presentation, we will attempt to have these questions answered. Dr. Li completed her radiology training in cardiothoracic imaging fellowship at Monash Health and subsequently underwent MRI fellowship with iMed Radiology. She currently works as a general radiologist in multiple iMed radiology clinics across metropolitan Melbourne and as a staff radiologist at Monash Health. Her MRI accreditation sees her reporting all body regions, including head, spine, musculoskeletal, MRCP, rectal, prostate and cardiac. She believes MRI is an excellent tool to provide additional diagnostic information, which may be better and more appropriate in some circumstances than their other more traditional modalities. Although MRI is becoming more readily accessible to patients, Jourena believes it remains an underutilised tool by GPs, and she wants to take this opportunity to share her MRI experience with you all, with the aim of working together for improved patient outcomes. Thanks. Over to you, Jourena.
Thank you, Dr. Polstein. Thanks, Ahmed, and Dr. Polstein for the kind introduction. So today I'm going to be talking about some common sort of case studies, some considerations and contraindications at the main kind of basics of what you need to know about MR. So we're going to briefly touch about what's MR, some safety considerations and contraindications, 3T versus 1.5T, what's the difference, which one is better, how do you choose, and then we're going to be briefly talking about Medicare licensing and regional deregulation, some Medicare rebates and why we charge the gaps, and also we're going to be talking about some contrast used in MR and its safety sort of concerns. And then we're going to go through some common case studies. And at the end, we're going to be answering some questions. So during any time of my talk, please feel free to drop us any questions and we'll address them at the end of the presentation. So starting with some very basics of what's MR, it's essentially, machine produces a magnetic field which aligns with the hydrogen atoms which are abundant in the body, and then we apply radio frequency pulse which then aligned with the hydrogen atoms. And when the protons are returning, so protons that contains in the hydrogen nuclei, when it's returning to their original position, they emitted a signal which is then detected by the MR coil, and which then creates images. So all involves is magnetic field, so there's no radiation involved, not like CT or fluoroscopy or X-rays, which is a very important aspect of MR and very sort of useful in people, for example, pregnant patients and young patients, as well as sort of patients who potentially sort of are concerned about radiation exposure. So the other thing that MR is really good at is looking at soft tissues, for example, in particularly in the MSK imaging. We all know that X-ray and CTs are really good at looking at bones, whereas ultrasound can be useful in detecting or evaluating superficial soft tissues, but some of the deep soft tissue structures are much better evaluated with the MRI, and I've got some more case studies at the end to show this. So the most important thing is the safety considerations when you're ordering an MR test, and always say that any patient with any metals in the body, any kind of cardiac pacemaker, any prostatic heart valve, stents, aneurysm clips and cochlear implants, or any kind of vascular stents, or any joint replacements. So ideally, it would be nice to put it in the referral so that our sort of administrative person as well as radiographers can actually protocol those patients, and we can try to get additional information about those prostheses from the patient before we book the patient in. So for example, a very common scenario would be a patient who's got a cardiac pacemaker in situ, who needed, for example, an MR of their brain to look for a bleed or an aneurysm. So what happened to those patients is that it really depends on the type of the mode and the how many leads there are present, which then sort of tells us whether the patient is safe to have the MR or not. Because some of the pacemakers, some of the older models of pacemakers are not MR safe. whereas most of the newer types of cardiac pacemakers are MR conditional. And some of it could be only conditional, MR conditional to 1.5 T scanner, and some of them can be compatible with a 3T scanner. So those are the information that we need to get from the patient or from the cardiologist to decide on what type of pacemaker, what type of scanner can we put the patient in safely. And also, once we've decided on that a pacemaker is MR safe, then we'll usually need to get the MR technician to come in and check the pacemaker to make sure that the leads and the pacemaker is functioning well. And once the patient's finished with the MR study, they'll have to be checked by the technicians to make sure that, again, the pacemaker leads are still in the right place, and also the pacemaker is working well. So quite a lot of safety check before we can safely put the patient into a MR scanner. So please be aware that such information would be quite useful for us before you order order an MR for a patient. The other thing is metals in the body. So welding, patient with a history of welding, grinding, any kind of shrapnels in the body. That's also really important for us to know. For example, really depends on the location of the metals. If a metal, for example, is very close to a vital organ such as a blood vessel, so once the patient go into the scanner, the magnetic field can actually cause the metals to vibrate or to migrate, in which case, if for example, if the metals in the blood vessel, then that can cause the blood vessel to rupture and leading to catastrophic sort of bleeding, and it can be quite dangerous. So those information are really important as well. I guess the other concern is patient with claustrophobia. So a couple of things that we can potentially do to try to help with the patients who's got claustrophobia, including, for example, a little bit of oral anxiolytics prescribed to the patient for them to be taken just before the MR study, and that would be useful to relax the patient. And if, for example, if the patient's tried oral anxiolytics and that still doesn't work, then depending on the region and depending on the local service providers, in some places, particularly in the hospital settings, we can consider giving the patient some IV sedation, for example, small dose of midazolam to try to help the patient relax and getting through the examination. So if you think a patient is claustrophobic, you can put that information on the request, and we can have a look and decide whether we're able to give the patient a bit of IV sedation or not. So just a bit of safety consideration there. Then we're going to move on to 1.5 T versus 3T scanner, and what's the difference? So essentially, it just means that 3T scanner produces a much stronger magnetic field strength, which then increases the signal to noise ratio and increase the image resolution and shorten the scanning time. So the images are usually sharper and has much higher resolution. However, 3T scanner is not necessarily better in the entire way. So once when the magnetic field strengths are stronger, they causes the image to be more susceptible to artifacts. So particularly when you're thinking about imaging patient's brain and spinal cord, those images can be more prone to pulsating artifact from CSF. So for example, if you've got a patient with multiple sclerosis, then when you're trying to detect demyelination plus in the spinal cord, if you put the patient into a 3T scanner, the images may be more blurry because of the CSF pulsating artifact adjacent to the spinal cord. So it may in fact be better to scan those patients in a 1.5T scanner. However, in most of the MSK imagings, which isn't sort of prone to artifact motion or motion artifact, then those images evaluating the chondral cartilage or the ligament, the cruciate ligaments or the meniscus, those images can usually be a lot better on the 3T scanner. And also, I guess, it really depends on the availability in your local regional service provider, whether they've got a 1.5T or 3T. I think the other thing is those patients with pacemaker and implants, depending on the type of pacemaker and the implants, some of the pacemaker and implants, they might not be suitable for 3T scanners. So in those cases, if you tell us that the patient's got those pacemakers or implants, we can kind of then hook the patient into the appropriate machine. Very briefly about Medicare licensing and regional deregulation. So usually, our MR machines can be either fully licensed or partially licensed or do not have any license. And what does it mean is that a fully licensed MR machine can be accessible to Medicare rebate. And partially licensed machine can only be accessible to part of the Medicare items. But that partial licensing is usually kind of affecting specialist referral a bit more. I don't think it sort of affects GP referrals. So for all the GP referrals, you don't really need to worry about partial or fully licensed machine. So the other thing is regarding regional deregulation. So since 1st of November 2022, all of the modified monarchy area 227, which I believe includes all the rural, the regional, and also the very remote areas. So all of the MR machines in those areas will have access to Medicare rebate. So those machines don't really need to have a license to access Medicare rebate. So all of those patients getting done in those machines will be eligible to receive Medicare rebate. And why do I have a mixed billing policy? You'll probably find that depending on the different region you're working at, different places will have different billing policies. Some places would charge a gap and some places won't charge a gap out-of-pocket fee for the patient. And that's predominantly just to cover the increase in costs related to inflation and supply chain issues. And if you do think that the patient is in a financial hardship or is a concession card holder, put it on the request and we can try to reduce the out-of-pocket fee for the patient or bulk bill the patient depending on the location. The other, I guess, safety sort of concern is some of the MR study involves contrast administration, and what we normally use in a MR study is gadolinium-based contrast versus normally in a CT examination we use an iodine-based iodine-based contrast agent. Both are regarded very safe, and as you're probably aware, there's 0.5 to 3% of mild reaction related to a CT contrast, 0.004%, so less than 1% of severe reactions related to CT contrast agent. And that's very similar with gadolinium-based contrast, with 0.5% for immediate reaction and 1 death per 5.26 million doses over 10 years of time. So I guess the other, just briefly touching about the contrast safety of gadolinium-based contrast, there has been a lot of concerns regarding nephrogenic systemic fibrosis that's related or caused by gadolinium-based contrast. And that's usually because gadolinium is a medication that's excreted by the kidneys. So any patient with renal function can potentially have issues of gadolinium sort of retaining in the body or hanging around in the system for longer than expected. Most of the reported case of nephrogenic systemic fibrosis are related to older type or older generation of gadolinium-based contrast, whereas nowadays most of the modern kind of gadolinium-based contrast we use are more macrocyclic related sort of gadolinium. So there are different types of gadolinium-based contrast. The older types are usually related to a linear carrier ligand, and the newer ones are more towards the macrocyclic. And the macrocyclic sort of ligand gadolinium are thought to be a lot safer, have very few cases of reported nephrogenic systemic fibrosis. So essentially, in a nutshell, it's a very, very safe sort of contrast media to use. And there has been some concerns also recently over the media, concern about gadolinium retention in the body tissue, for example, in the cerebellum, in the dentate nucleus, as well as in the basal ganglia. But so far, there's no reported adverse outcomes associated with gadolinium retention. So a very safe contrast agent to use, and obviously in a patient who, in pediatric patients or patients who are pregnant, because of at the moment, the data are limited. We don't have a lot of knowledge about the safety, so we kind of tend to avoid using them unless it's absolutely needed. But I guess you don't really need to worry about it when you order an MR. Usually, once you tell us the clinical question, usually the radiology practice will decide on whether a gadolinium contrast is necessary or not. And usually, sometimes we'll do the non-con scan, and one of the radiologists will review the scan, and then we'll usually decide it on the spot whether it needs to be whether we need to do any post-contrast images or not. So I guess MRI is a very useful test, but don't order it because the patient wants it, or because it's bulk billed, or if it's cheaper, or if the patient thought to be has claustrophobia, or if you think the availability is thought to be sooner. Because a lot of the times I see a lot of, I guess, referrals where I guess people generally think that because MR doesn't involve radiation, it's a better test, it's going to tell you a lot more information. However, for example, in a patient with where you're worried about fracture, it's probably just it gives a better image looking at the bones, and it's more accessible to the patient, and it's a much quicker scan. So if you're looking at the bones, CT is probably still X-ray or CT is still probably a better test. But if you're looking at soft tissues, then MRI is going to be a better test. So going to skip that. So just an example of, for example, looking at menisci or cruciate ligaments or any cartilage, articular cartilage, obviously MRI is still the best test, and ultrasound won't be able to give any useful information regarding those structures. So most importantly, when does your patient get Medicare rebate? So for any patient over 16 years of age, if you order an MR brain for example, unexplained seizures, unexplained chronic headache with suspected intracranial pathology, those are all gonna be Medicare rebatable scans. So patient will have reduced out-of-pocket fee if if any out-of-pocket fee for the patient, depending on the local service. And also any MR cervical spine looking for trauma or radiculopathy, any knee MR request in a setting of meniscal tear. If a patient has had a recent trauma, just a note there, any of those patients who is older than 50 years of age, unfortunately, will not be eligible for Medicare rebate. So any patient between 16 to 49 years of age with recent acute knee trauma, if you're looking for meniscal tear or cruciate ligament damage, then those patients should have Medicare rebate. So in pediatric patients, Medicare kind of rebate criteria and type of scans are a lot more sort of than compared to an adult patient. For example, elbow, there's some sort of if you're looking for fracture or avulsion injury of a suspected sort of elbow pathology, or if you're worried about scaphoid fracture in a wrist, or if you're worried about internal derangement in a knee MR, if you same with MR, if you're worried about intracranial pathology in a setting of seizure, chronic headache, those are all rebatable, and some of the MR sort of criteria are very similar following trauma or unexplained neck or back pain. And some sort of knee MRs are also Medicare rebatable, including suspected septic arthritis and slipped capital femoral epiphysis, or if you're worried about Perthes disease in those patients, they're all going to be sort of Medicare rebatable. So we're going to be going through some of the case studies, which I think hopefully that'll show you that hopefully that'll clarify sort of some of the common questions of when should you order X-ray, when should you order an CT versus ultrasound versus MR. So first case is a 40-year-old patient who has lateral knee pain, and we can see that and the patient had a recent fall after a soccer match. So we can see that we've started with an X-ray, which demonstrates that the patient has had a previous ACR reconstruction. The tibial and femoral condyle sort of screws are all in very good alignment, and we couldn't see any fracture. There's no evidence of knee joint effusion or any lap or hemarthrosis to suggest any occult intra-articular fracture. We also did an ultrasound looking for ligamentous damage, and that has been normal, but the patient's having ongoing sort of lateral knee pain, so ended up doing an MR. So we can see that there are two MR images there. On the left side, I've pointed to a you can see that there is a linear hyperintensity at the anterior horn of that lateral meniscus, which is consistent with a meniscal tear. And the right MR image is slightly more medial compared to the first image, so it's close to the intercondyle canal, because we can see the ACR and the PCR adjacent in the image. And what the red arrow is pointing to is a displaced and migrated and flipped sort of meniscal fragment. So this is a bucket handle tear of the lateral meniscus. Of course, I would not expect ultrasound to pick this up, and this can only be evaluated on the MR. And I've got the next image, which is an axial image cutting right through the meniscus, where my red arrow is pointing to, and that's the lateral meniscus, and where the red arrow is pointing to is the flipped sort of meniscal tear and the fragment, which resembles a bucket handle, and that's why we called it a bucket handle tear of the lateral meniscus. Next case is another patient with previous ACR reconstruction presented with gradual worsening of anterior knee pain 2 years after their ACL reconstruction. So again, we started with an X-ray, which looks normal, did an ultrasound, also normal, couldn't find any obvious cause for the patient's pain. So ended up doing an MR, which showed that there is this hypointense lesion in the anterior intercondylar canal, where my red arrow is pointing to, and it's that lesion is hypointense on all sequences, so on PD, on T2, as well as T1 sort of weighted images. So that's consistent with a cyclops lesion in a patient with a previous ACL reconstruction. So again, this type of sort of pathologies are much, much better evaluated on the MR rather than, for example, ultrasound or X-ray. Here is another example of patient with osteoarthritis of the patellofemoral compartment. So we can see that the left side image is a sagittal image of the patellofemoral joint, and the right hand side image is an axial image of the patellofemoral compartment. So we can see that there is full thickness chondral wear of the patella as well as the femoral trochlea, and we can see that there are also multiple areas of subchondral bone marrow edema as well as cyst in both patella as well as in the femoral condyle. And also on the MR, we can actually see that the patella is laterally subluxed, so it's quite laterally positioned in relation to the femoral trochlea. Also the femoral trochlea groove is very shallow. So those findings are suggestive of a background of patellofemoral maltracking, which then predisposes patients to getting premature or exaggerated osteoarthritis of the patellofemoral compartment. So much better, again, much better seen on the MR rather than ultrasound or X-ray. Next case is a young patient who has presented with a history of previous anterior dislocation of the shoulder. So the two images, the left one is the CT image of the left humeral head, and the right hand side image is a mirror image of the same level on the MR study. So we can see that there is a defect at the superlateral aspect of the left humeral head where my red arrow is pointing to, and that's consistent with a bony Bankart lesion in a patient with previous anterior dislocation. And the next slide is looking at the glenoid. So when a patient anteriorly dislocate the shoulder, their posterolateral humeral head kind of collides with the anteroinferior aspect of the glenoid and causing a Bankart lesion. So the CT image on the left-hand side shows a small kind of displaced avulsion fracture of that anteroinferior glenoid. However, it's very difficult to evaluate the soft tissue structure, for example, the labrium, as well as the periosteum, and also the cartilage, sort of anteroinferior glenoid cartilage, whereas it's very well appreciated on the MR image on the right side, that we can see the black triangle adjacent to the anteroinferior glenoid, and that's the labrum, and we can see a hyperintensity through the base of that labrum, so that's consistent with a labral tear. And we can also see that the curvilinear sort of black structure adjacent to the anteroinferior glenoid, and that's the periosteum of that glenoid, which has been peeled off because of the dislocation and trauma to the glenoid. So again, soft tissue structures are much better evaluated on the MR. We won't be able to comment on any of those labrium or cartilage on the CT. This is another case example, another shoulder in a young patient with sort of long-standing deep ache in the shoulder. So I think the clinician were worried about a labral tear, so ended up doing an MR. We can see that there is a lobulated, bright cystic lesion adjacent to that superior labrum, and we can, on the right-hand side image where the arrow is pointing to, we can actually see that there is a little tail coming off the cystic lesion. Extending into the base of the labrum. So this is a superior labral tear that's then associated with a paralabral cyst, which is the lobulated cystic lesion adjacent to that superior labrum. So because of the patient has been very symptomatic and it's a young patient, I think the patient ended up having surgical repair of that labrum and excision of that paralabral cyst. Here is another example of patient who has acute fluid frozen shoulder. So this patient presented, I think, with a few weeks history of severe shoulder pain with globally reduced sort of range of movement of the shoulder joint. And we can see it on the coronal as well as on the sagittal images that there is quite extensive edema, which is shown by the brightness around the shoulder joint. So that's extending inferiorly to the axillary recess, superiorly into the involving the rotator cuff interval, as well as anteriorly sort of adjacent to the subscapularis. So this patient ended up having a hydrodilatation of the shoulder, and the symptoms has improved after the shoulder hydrodilatation. So here is another example of the same condition, so frozen shoulder. However, this patient has had the pain, I think has had the symptoms for 12 months, so kind of towards the late stage of frozen shoulder. So we can see that the left-hand side image pointing to the axillary recess, which is formed by the inferior glenohumeral ligament. It's very thickened. A very sort of you can see that dark sort of band of excess of the axillary recess there. On the right-hand side image, we can see that where the arrow is pointing to is the rotator cuff interval, which is often sort of affected in a patient with frozen shoulder. So we can see that there is very abnormal infiltration of the fat in the rotator cuff interval. So in a normal patient, the rotator cuff interval should be just fat containing. So it should be as sort of clean and as bright compared to the subcutaneous tissue, whereas in this case, it's very gray. So it's abnormally infiltrated by all this inflammatory process that's happened with frozen shoulder. So all of those images, again, very difficult you won't be able to see any abnormalities on X-ray or CT. Occasionally, I guess we don't really, occasionally, depending on the size of the patient, if the patient is a skinny, healthy sort of young patient, we may be able to see the thickened inferior glenohumeral ligament on the ultrasound, which may then kind of point towards the diagnosis of frozen shoulder, but much easier to diagnose on the MR. Here is another case with in a patient with known history of sort of extensive rheumatoid arthritis. So you can see on the X-ray, we can see that there are multiple erosions at the humeral head as well as at the glenoid. However, the middle and the right-hand side image, we can see a lot more details associated with the inflammatory condition with the rheumatoid arthritis. You can see the erosions much better. You can kind of measure the size of the erosions, and also you can see that the gray kind of area adjacent to erosions, very thickened and inflamed synovium related to the rheumatoid arthritis. We can also see that because of the severe rheumatoid arthritis, patient actually has, this is a young patient, I believe she was only 30 or 40 years of age. So we can actually see that there is very extensive chondral wear in the glenohumeral joint, as well as subcortical sclerosis. So there is two pathologies at the same time. So there's rheumatoid arthritis as well as exaggerated or premature osteoarthritis of the shoulder joint. Again, much more details and information we can get from doing an MR rather than just looking at the X-ray. A couple of cases moving on to neural imaging. So here is a sort of comparative slice of a CT and an MR in the same patient. We can see that there is a disc bulge at the level of C5 and C6. Much better seeing on the MR. We can actually see the intermediate bulge, disc bulge related, extending into the spinal canal, whereas on the CT, very difficult to see the disc bulge. I guess also relate, I guess the other reason is this patient, as you can see from the subcutaneous tissue, this patient has elevated BMI. So images of the lower cervical spine can be very noisy in those patients with elevated BMI. So, and also particularly towards the lower cervical spine, because of very thick sort of overlying soft tissue from the root of neck as well as near the shoulder joint, the signal in those regions tend to be affected by a lot of noise coming from the surrounding soft tissue. So this type of disc bulges are much better seen on the MR rather than CT. So this is the same patient, just showing you the actual image of that disc bulge. And also you can see on the right-hand side MR image, you can actually see the spinal cord really well. And you can see that the disc bulge is actually indenting and flattening the right anterior spinal cord. Whereas on the CT image, you can't really tell where the spinal cord is, and you can't really assess for any kind of spinal cord compression. On the MR, you can also look for signal abnormality that's related, and sometimes when there is severe spinal cord compression, which leads to myelopathy. So you'll be able to assess the signal abnormality of the spinal cord much better than CT. Here is another sort of similar type of disc bulge in the lumbar spine at the level of L5/S1. You can see the sort of dark sort of disc material extending into the spinal canal, whereas it's very difficult to see it on the CT image. And also, again, this patient is a larger size patient. You can see the amount of subcutaneous tissue there, which then increases the noise, and which makes assessment of disc bulge even harder. And this is a axial image of the same patient showing the disc bulge compressing the nerve roots in the spinal canal. So on the right-hand side image, you can see that the little black dots are all the nerve roots that's compressed and posteriorly displaced by the focal disc bulge, whereas on the CT, you can't really tell where the nerve roots are, and obviously you can't really assess the nerve root compression. So moving on to some brain imaging. So just remember, for Medicare rebate items, you can refer patient with either seizure activity or chronic headache. So unfortunately, stroke, if you're worried about stroke, unfortunately, it doesn't attract any Medicare rebate. However, unfortunately, a lot of the times for small areas of recent or acute infarct, MRI is still the best modality or the best imaging to assess for those changes. So this is a patient with acute infarct in the left corona radiata that's demonstrated by the right-hand side diffusion weighted image. So the red arrow is pointing to a small area of diffusion restriction, which is the bright sort of area. and a comparison image on the CT. On the left-hand side, you can see that you can't really see any abnormalities in that region. So for small areas of infarct, particularly if it's not involving the entire cortex, it can be difficult to see on the CT, particularly also when the infarct is very recent. So usually, we usually say that infarct less than 24 hours of age would be very difficult to be picked up on a normal CT brain. Even if you do a post-contrast CT, the sensitivity is still very low for early infarct, as well as sort of small area of acute infarct. So this is the same patient. Sorry, it belongs to the same patient. This patient has multiple kind of embolic infarct in that left MCA territory. So the previous slides was showing the infarct in the corona radiata, and this slide shows the infarct in the left insular cortex, which is also supplied by the MCA territory. So in patient with, for example, if you worry about a central embolic source from, for example, endocarditis, MRI, it would be the best modality to look for those pathologies rather than CT. Here is another young patient presented with long-standing history of headache. So did a CT, very difficult to tell on the top left image what's going on, just a little bit of hyperidensity in that left frontal cortex. So we ended up doing an MR, which shows the lesion much better. It's a T2 hyperintense lesion that's causing expansion of that cortex, so in keeping with a neoplasm. So this lesion doesn't have any contrast enhancement, doesn't cause any diffusion restriction. So this is a low-grade glioma in that left frontal cortex. So I guess on retrospect, if this patient presented with long-standing headache, so I guess this patient could well be, we could sort of well ordering the MR rather than doing the CT. And eventually this patient needed an MR for the diagnosis of a low-grade glioma. This is another case of a patient presented with sudden onset of headache, did a CT. On the top left-hand side image, we can see the intraparenchymal hematoma pointed by the red arrow. And on the same slides, we can actually see that there is a bit of calcification slightly medial to that area of hematoma, which is very unusual in a patient in the brain area. That's pointed by the blue arrow. So we ended up doing an MR, which demonstrated a hematoma again in that right frontal lobe. And medial to that intraparenchymal hematoma, we can see the serpiginous kind of area of flow voids, so darkness. So this is a patient with AV malformation, which has bled and resulted in an intraparenchymal hematoma. So we demonstrated that on the MRA, which I guess you can do a CTA to evaluate for that, but again, the nidus is much better shown on the MR rather than the CT. So I think I've got the final case, which is a patient with cavernoma in the left cerebellum. So initially we did a CT. So left-hand side image is a non-con and right-hand side is a post-contrast CT image. We can see that the lesion doesn't really enhance. It's kind of hyperdense, which is, I guess you'd be worried about, is it a bleed or is it a calcification? Very difficult to tell on the CT. Especially in the setting when the lesion doesn't enhance with contrast. So ended up doing an MR, which shows the lesion very well. So the typical appearance of this lesion is that it causes voluming artifact on susceptibility weighted image, which is the bottom left image. You can see that the calcium balloons up and shows as hypointense or dark signal. And the bottom right image is a post-contrast MR study of the same lesion. We can see that same with CT, the lesion doesn't have any contrast enhancement, which I guess would make sense in a patient in a lesion which is heavily calcified. It doesn't usually enhances with contrast. So another case showing that a lesion that would be difficult to diagnose on the CT, but much easier and much more confident with diagnosing it as a carcinoma on the MR. So that's the end of my presentation and the case studies. So we're going to be doing some sort of questions, and just be reminded that you can actually vote to the questions, and we'll look at the poll statistics in a few minutes. So the first question should be relatively easy. So CT is better for evaluating of bony structures. Is that true or false? So I'll give you guys a couple of seconds to put your answer through, and then we can look at the poll. Are we hoping that everyone's put their answer through? Just wondering if I can look at the results. So 75% have answered true, which is correct. So comparing to MR, I guess you can also evaluate for bone marrow edema on MR, which is not something that we'd be able to see on the CT. But if you're looking for example, fractures, then much easier to see on the CT compared to MR. I'm gonna exit to the poll and then go back to presentation, and we'll go to the next question, which is MRI is better for evaluation of soft tissue structure. Is that true or false? Should also be a straightforward answer. Should we close the poll? So we've got 67% of people, oh, actually 100% of people agreeing with me that MR is much better evaluating soft tissue structures. That's great. We'll go to the next question, which is slightly, I guess, slightly more complicated. So a patient who has a cardiac pacemaker who needs an MR lumbar spine will need, so do they need all of them? Do they need some of the sort of answers? So information about the brand, the type, the number of pacing leads to check the MR compatibility. Second option is it needs the pacing technician to check the setting of the pacemaker before and after the MR scan. And the third option is cardiac arrhythmia is a potential complication. Is that true or false, or are any of the dot points correct or incorrect? I think we'll close the poll and see. So I think looking at the statistics, 44% of patients thinks that yes, we need information about the brand, the type, and number of pacing leads. 31% of 31% of you guys thinks that we do need the pacing technician to check the pacemaker. 25% agrees that cardiac arrhythmia is a potential complication. So going to the answer of those questions. So yes, I agree. All of those are correct. So yes, cardiac arrhythmia is the major concern of putting those patients with cardiac pacemaker into this MR scanner without checking the above two information. So once the pacemaker once the pacemaker gets into the scanner, if it's not MR compatible, then potentially magnetic field can actually cause the cardiac pacemaker lead to change position or to malfunction or to prematurely trigger a pacing. So that could potentially lead to cardiac arrhythmia, can be dangerous. So that is also correct. So final question is, which of the below are MR rebatable? Slightly more complex kind of case question at the end. So 50-year-old with chronic headache, is that rebatable or not? 20-year-old with unexplained seizure, is that rebatable or not? 51-year-old with acute knee injury and suspected meniscal injury, is that rebatable scan? Or a 35-year-old with 2 weeks history of neck pain post MBA and suspected ligamentous injury, is that rebatable scan? By all of this, I'm referring to sort of GP referrals, since most of our audience are GPs. And next question is 70-year-old with neck pain with suspected radiculopathy. And the last question is 40-year-old baseball player with suspected shoulder microsensibility, is that rebatable or not? So I will give you guys a few minutes to answer the questions. I think we'll close the poll. So I think I'll just go through the answers. So out of all of those patients, unfortunately, the 51-year-old patient with acute knee injury and the suspected meniscal injury, unfortunately, does not qualify for a Medicare rebate, because those patients with acute knee injury and suspected meniscal tear, will need to be below 50 years of age. So unfortunately, that patient is not eligible. And also, unfortunately, any of the shoulder MRs are shoulder, wrist, or smaller joint MR studies are unfortunately not Medicare rebatable at the moment. So finally, just a very brief touch about silicosis, because recently there has been a lot of media sort of concerns of those artificial stone benches causing silicosis. So just a brief note that it's a very sort of specialized area to look for changes of silicosis. Traditionally, we look at them on chest X-ray, but I think the newer and the now current recommendation is to screening those patients with low-dose CT chest, because some of the very subtle changes, such as nodular opacity or ground glass opacities, can be very difficult to detect on the chest X-ray and much better seen on the CT. And IMED, we do any of those referrals will only be reported by specially accredited radiologists who look at who reports those studies according to the ILO classification and their sort of reporting templates. So just a note that we do have very specialized radiologists reporting those images if you do decide to refer those patients to us. And that's the end of my presentation. Thank you very much for your time.
Thanks, Jourena, so much for really comprehensive coverage of a very big topic. And thank you to all our participants for the host of questions that they've managed to pass on to us. I thought I might ask a couple of the shorter questions first of you, Jourena. The first one concerns the duration. How long does it take to have an MRI?
It depends on the area, body area. So, for example, a knee MR takes about 20 minutes for a comprehensive knee MR, and brain imaging similar for routine. For example, if for a routine brain imaging, sort of 15 minutes. But any of the complicated studies can take significantly longer. It could take up to half an hour or 40 minutes, depending on how many sequences that we need to get and whether we need to do any post-contrast imaging or not.
Thank you. The other brief question, an important one, is MRI. How about its safety in pregnancy for the mother and the fetus?
Yes. So scanning pregnant patients, usually we try to avoid it in the first trimester because of I think there has been some sort of study published concerning raising concerns about heating. So because of the magnetic field strength, it causes heating of the body, so heating of the uterus, causing potential damage to the fetus. The other concern is acoustic damage from the MR signal, as well as the radio frequency signal that's applied during the MR examination that can potentially cause damage to the fetus during the first trimester. But usually in the second and third trimester, the concern is, or the sort of, it's regarded quite safe, or the concern is much less.
Excellent, thank you. Somebody else asks, could you explain the difference between T1, T2 and STIR images briefly?
That is a slightly complex question. I don't really want to go into the complex MR physics of how the images are generated, but I guess in a practical kind of way, T1 and T2 are different, sort of looking at different relaxation curves when they require the MR image. Most of the pathologies are bright on T2, I think would be fair to say. And also the STIR image is a inversion image of a T2. So it's, you can also, so fluid, any kind of fluid as well as fat would be bright on T2, whereas a STIR image will suppress the fat signal, so it makes it bright only, makes it only fluid being bright. So that's the way of sort of telling which is edema and which is fat. So looking at comparing the T2 and the STIR images. And T1 images are usually, most of the pathologies are dark, but I guess it's probably too general to say that a few things are bright on T1, including blood, calcium, melanin, some of the paramagnetics, for example, gadolinium, or proteinaceous fluid can be bright on the T1. So unfortunately, they're very complex physics behind it, but the most useful, I guess, for general people is to, if you want to see a pathology in 1 second or within 3 seconds, you just go to the T2 or the STIR images, and hopefully most of the pathologies are going to be bright and be very easy to see on the T2 and STIR images. Is that helpful?
Yes, helpful. Important question. How useful is ultrasound of the knees? I particularly want that to be asked because I see quite a few people that have had ultrasounds, and I think they have not been very beneficial. I'm not sure how you feel.
Yeah. So ultrasound of the knee is very good at looking at, for example, if you're worried about joint effusion, if you're looking for synovitis, if you're looking at all the superficial tendons and ligaments, for example, the quadriceps tendon, the patella tendon, medial and lateral collateral ligaments. Because when we're imaging ultrasound the knee, we looking at, we either imaging medially or laterally, looking at evaluating the meniscus. So we can only see sort of the body of the meniscus. So any kind of deeper structure or deeper structure of the meniscus will be very difficult to see on the ultrasound, and obviously cartilage would be not very well assessed on the ultrasound.
Okay, thank you. I just at this stage want to remind everybody that if we don't get time to answer the questions you've posed, We will attempt to have them answered on the IMED website in the next week or two to follow that. Suresh asked, is MRI a better investigation for frozen shoulder than ultrasound?
I think usually when we try to diagnose frozen shoulder on ultrasound, we rely on those secondary features. So the patient, relying on the patient's limited external rotation. And also, I guess the other important useful thing that ultrasound can rule out is any kind of rotator cuff pathology or any subacromial bursitis that could potentially be an alternative cause for the patient's shoulder. So once we've excluded the rotator cuff pathology or bursitis, then if the patient do have, for example, limited external rotation, if we happen to see that there is thickened axillary recess or inferior glenohumeral ligament, then we would be very happy to say that it's frozen shoulder. But a lot of the times ultrasound, my sort of understanding is that we usually use it to exclude other pathology that can cause the patient's pain. And again, as I showed, MR has a much better sort of chance of diagnosing frozen shoulder.
Thank you. Alice asks, is there a risk of gadolinium contrast being retained in the brain with repeated breast MR in a high-risk cancer patient?
I think at the moment, unfortunately, there isn't a lot of published study looking at a long-term effect in those patients with retained gadolinium contrast in their brain. So it's something, unfortunately, we'll need to see, but in the long term. But at the moment, there is no reported adverse effect regarding that.
Look, thanks so much, Jourena. There are a lot more questions, and as I mentioned before, we'll try and get them answered on the website in the following weeks. I'd like to thank you very much, Jourena, for an excellent presentation and very relevant to us as GPs. So thank you so much. And now I'll just pass back to Ahmed for concluding remarks.
Thank you, Dr. Pearlstein.
Thank you, Dr. Li and Dr. Pearlstein, for such an informative and insightful evening. I'd also like the opportunity to thank our audience for joining us tonight. We look forward to your feedback. So can I ask you to stay online, where you'll be redirected shortly to complete your evaluation. Stay safe, stay well, and good night.